So now we always go off the, excuse me, the Edinger chapters. Did anybody get a chance to read them?
Yeah.
Yeah. Well done. Thanks. Excellent. Did you find them interesting?
Yep. The hypertension one was cool. I was going to ask how often you actually need to like intervene with nitroprusside and all that sort of stuff, because I've never seen it happen. So yeah, I was curious to see like how common that is, whether you get like the scary hypertension. Because I've seen lots of animals with like end organ damage, like cats with like systemic hypertension, and they've got like, I don't know, like a detachment or something, and then they just get put on amlodipine usually, and that's sort of that. And I'm wondering if that's like the appropriate way to manage those, or
it absolutely is, actually.
Yeah, okay.
Pretty well, any patient that can tolerate oral medication, or if you've got transdermal amlodipine, I would use that. It's the best anti-hypertensive,
Okay.
best and safest with the lowest side effects, I would say.
Okay, cool.
Them. Nitroprusside, you can push it too far really easily, and they become hypertensive.
Right.
Which is quite catastrophic. And the only indications that I use it in, or I've seen it used in, are in dogs with heart failure.
Right. Okay.
So if you think about the sort of, and most dogs have degenerative mitral valve disease as their cause of failure, so that when their heart pumps, most of the blood goes out into the aorta, but some of it's going back up into the atrium through that leaky valve. So if the pressure in the aorta is high, if they're hypertensive and the heart pumps, it's going to be harder for the blood to come out of the heart and easier for the blood to regurgitate back up through the leaky valve. So we talk about, in humans, they use the terms ejection fraction, so percentage of the cardiac output which goes into the aorta, which is ejected, and the regurgitant fraction, which is the percentage that goes back up into the atrium. So if you've got hypertension, your regurgitant fraction is higher, and obviously that's going to exacerbate or compound congestive heart failure if they've got terrible pulmonary edema. You can only really use it in dogs that are hypertensive, or if they're normotensive and you just want to drop their blood pressure to the low end of normal to try and improve the ejection fraction and decrease the regurgitant fraction, just to get them out of a crisis very short term.
Right.
But the other thing, it's sensitive to light too, isn't it? Because remember when we used it in the States, we had to wrap the drip lines in foil.
It's really...
So okay.
We've got it in the hospital and it comes in like a foil bag to open. But yeah, it's a medication that's hard to use, and it's also one that's finicky, and you want to be experienced in using it when you use it. So we use it very rarely, and that makes us probably use it more rarely because it's risky and makes us nervous.
Yeah, right. Cool. All right. Yeah, I saw it in the flow chart and I was kind of like that. Oh, never seen that used.
Not very often. Amlodipine is just so effective. We so rarely, I mean, unless the dog's like really vomiting and can't keep anything down, it's usually the first port of call.
Great. Cool.
Because I'm medicine, I really like the pathophysiology section of this chapter. But I was interested that it didn't actually go into that much detail, and it did sort of make me think, oh gosh, we do a lot of kind of physiology background with, all the hormones and stuff that we're talking about. There's a lot of assumed knowledge there. So if we sort of just essentially work through the chapter quickly and talk about the sort of mechanisms that can cause, that contribute to blood pressure. How am I going to word this question? So there are two things really that contribute to the blood pressure. What are they?
Blood volume and systemic vascular resistance, or?
The cardiac output.
Beg your pardon, Catherine?
The cardiac output?
Cardiac output, exactly. And blood volume is a component of cardiac output, but it's not all of it. So if I say two categories, cardiac output and peripheral vascular resistance, so the tone in the blood vessels are the two big things. And then what are the two contributors? Blood volume is one of them to cardiac output.
And the heart rate.
Yeah.
Yeah, exactly. Good. So what so there's two kind of, if we just talk about the hormonal things that contribute to blood pressure, what are the two big hormones that contribute to blood pressure maintenance?
RAS, the RAS system.
Yeah.
So
Good.
renin.
That's good. Yeah.
Yeah, and then I guess your to controlling your heart rate would be like, you know, your adrenaline, your catecholamines and all that.
Definitely. Yeah. So sympathetic nervous system and RAS are the two big ones. Very good, Paul.
Yeah, it's I love this topic.
It's good. It's really interesting. Max is coming too now, so we can pester him with questions also. So then, as far as the kind of impact that the sympathetic nervous system has, what does it act on to cause hypertension?
On the heart rate, so cardiac output.
Yeah. And
I guess and vascular resistance, because you can
Excellent. Yeah. So there's adrenal receptors all over the cardiovascular system, so heart and vessels. So that's one of the biggest controllers of short-term changes in blood pressure. And what about RAS? How does RAS impact blood pressure?
RAS is working on blood volume, fluid retention. So RAS triggers ultimately the release of aldosterone, which then saves sodium, which keeps water in the system as opposed to being excreted from the kidney.
Good. So you mentioned aldosterone. What's the other A in RAS?
Angiotensin 1, 2, and 3, I think, isn't it? It's like there's 3. Yeah, 1 and 2.
Yeah. What do they do?
Oh gosh. I think I'm going to need help here. I can never get this pathway.
So I think the angiotensinogen is produced in the liver, which goes to angiotensin 1, and then this acts, I think, in the lung and in the kidneys to angiotensin 2, which will play a role in sodium retention, and I think chloride excretion, but I'm not sure.
Think about the origin of this word. Angio means
heart. So vasoconstriction.
Vasoconstriction, exactly.
Right.
Yeah, good. Catherine, excellent pathway of angiotensin metabolism.
Yeah, that's impressive.
Yeah. So you mentioned the conversion of angiotensin 1 to angiotensin 2. What's the enzyme called that does that conversion?
It's
angiotensinogen, isn't it?
That's the one that does.
It's angiotensin converter enzyme.
Yes, ACE.
Oh, nice. ACE.
Yeah.
Right. Oh, yeah.
Relevant?
ACE inhibitors. Yeah, right.
Light bulb.
I hate when that. God, I probably should have had that moment at vet school, but okay.
You can have them multiple times. I have those moments when I'm reading papers, and then I clean up my office and I realise I've read this paper 4 times before, and I've obviously had that moment 4 times before. Okay, excellent. So that's just a little bit of sort of background hormone physiology, which I just wanted to cover because we just talk about so much in this chapter. And I just want to jump really straight into the conditions associated with hypertension. And it was interesting, actually. I thought this chapter was really interesting because it went into the human perspective. It discussed all the conditions that contribute to hypertension in humans. and then gave us but that doesn't actually happen in dogs and cats. And I think that's really relevant because so often you're talking to somebody and you're saying your dog's hypertensive or your cat's hypertensive, and they say, I'm hypertensive. And it's just such a different syndrome, and it's nice to be able to sort of say, oh, you know, that doesn't actually happen in humans, or that doesn't happen in dogs and cats. I'm just going to shut my office door because it's so noisy in my house. I think my family's playing handball downstairs. Yeah, hop up here, please. Hop up. Okay, so the general stuff they talked about with hypertension is that it's signalment is important, which I guess obviously we sort of think aged animals more prone to hypertension, more prone to the diseases which contribute to hypertension. But I didn't know it was male dogs were overrepresented. So I thought that was interesting. So older male dogs have a higher incidence of hypertension than any other sort of subgroup, but there's no breed specific. Apart from greyhounds, which tend to have a systolic blood pressure at least 10 to 20 over what the rest of the population have. But if you send the owners home with blood pressure monitoring over the course of 24, 48 hours, the normal blood pressure for a greyhound is like the same as other dogs. They're just the white coat effect in them is stronger.
Okay.
So then cats, older cats in general, without any underlying conditions identified, will have a higher BP, which is related to their age, and they'll also have a higher heart rate. And I do wonder whether that's underlying conditions which aren't yet detectable, so like maybe borderline overactive thyroid, borderline renal disease that's not necessarily evident on blood tests yet. But certainly there's BP and heart rate effects associated with age in cats. So then that's sort of the signalment. What about obesity in canine and feline patients? Does that contribute to hypertension?
No.
I think so.
I thought so too, but it's actually, there's no studies, so it's really well documented in humans, but it's not an issue in dogs and cats. Max, are you here? Oh, there you are. Got you. Sorry. Now I can start quizzing you now that I know you're here.
Oh, okay.
Nice try sneaking in.
Oh, no, sorry, I was a bit late.
No, it's all right. So obesity is not really an issue. Kidney disease is for sure the one that we see most commonly causing hypertension. Do you guys agree clinically?
Yeah.
Yep.
Yes.
So what are the mechanisms of hypertension in feline chronic kidney disease?
I think it's the RAS system.
Yep. Good. Which will lead to?
The fluid retention and increased vascular tone because of the angiotensin.
Excellent. So theoretically, if you measured renin and aldosterone, what would the levels be?
I think the aldosterone should be elevated.
Yep, excellent.
And the renin, is that a trick question? I think renin should also be elevated.
It should also be elevated. I agree, but it's not. So a couple of different reasons. Where is renin produced?
Lung and kidney.
Good. So decreased kidney function. Yeah. So this is theoretical. We don't really have causation sort of demonstrated in veterinary literature. And I guess the other thing is that once that RAS system is activated, and you've got increased fluid retention, then the stimulation for renin secretion is not going to be as high. So I guess I don't know that for sure, but it's potentially a sort of feedback thing. But yeah, renin is usually low normal in cats with chronic kidney disease. So can you, Max, do you know if I said AKI, CKD, what would you, and I said which one's more likely to cause hypertension, which would you say?
I'll say AKI is more likely to cause hypertension.
Good, excellent. Why is that?
I think AKI, I think AKI causes more fluid retention because the renal output is less, is going to be impaired, unless they are in the polyuric, dipstick phase. But
I'm going to challenge you a little bit. If I said glomerular disease versus nephron disease or versus tubular disease, which of those two is more likely to cause hypertension?
Glomerular disease.
Good. So when we're looking at CKD, usually is a tubular disease, or tubules more affected than glomerular. Whereas acute kidney injury, we've got active injury to the glomerulus and activation of the local homeostatic, like the local glomerular blood pressure homeostatic system, which becomes dysfunctional. So I guess there's more acute activation of the glomerulus and therefore more acute RAS activation. And also the other system that contributes to blood pressure, so sympathetic nervous system, is going to be more activated in acute disease than it is chronic.
Okay.
Did anybody else have any kind of questions or discussion points on kidney disease?
I have a question, Anna, which you may have mentioned because it's kind of dropping in and out here.
Sorry.
That's all good. When you were talking about renin and aldosterone levels, how would you differentiate primary hyperaldosteronism and secondary hyperaldosteronism secondary to chronic kidney disease? How would you differentiate those two if you've got a reflex?
Did you say, sorry, it just dropped out a little bit. Did you say that, how would you differentiate between primary and secondary hyperaldosteronism?
Yeah, like if we're testing for renin and aldosterone and we find that aldosterone is quite high, the renin is normal, it sounds like that can also be just secondary to kidney disease.
Yeah, potentially.
Like how would you kind of know, is there a way to know or just not really?
So if you've got primary hyperaldosteronism, what's the syndrome that causes that?
You're like, isn't it idiopathic generally with like cons or something like that? Or tumour, neoplasia?
Yeah, so normally neoplasia, not excess aldosterone production. So what should the renin be if we measure it in that situation?
Quite low, I would have
Very
thought.
low.
Like not readable.
Yeah, exactly. So that's where it's the ratio that's important rather than the actual numbers themselves and where they sit in the normal range. So if you've got a sky high aldosterone and a low normal renin, that's inappropriate. And you've got to say, surely, if it was RAS activation, renin should be high. But interestingly, that's just not the case, particularly in renal failure, which I think is decreased ability to produce renin, whereas primary hyperaldosteronism is going to cause fluid retention, which is going to tell the kidney's just going to be saying stop, and renin is just going to be non-existent because it's going to be the kidney's going to be delivered so much fluid. Does that make sense?
It does make sense, yeah. I was kind of getting, because then when we were talking before about how it would feed back and the kidney would be trying to stop when it's got enough in the chronic kidney disease scenario, it just got confusing.
Yeah. Sorry.
confusing is good.
Confusing is better.
I learn more, so that's good.
I think that rings a bell because a while ago we sent off sample to RPA to do renin and renin and aldosterone ratio, and it came back. It's actually very unreliable for dogs and cats because there's no assay for dogs and cats in Australia.
Oh, right. Yeah.
We have one pending as well. I don't know if it's back yet. I haven't looked.
We submit them through Vetnostics. So
Vetnostics, well, there was a few months ago, they said they don't do it, so we have to call RPA to do it.
okay.
Yeah, this one was through IDEX, I think.
Oh, really?
You do it through RPA.
Oh, right. Okay. Oh, RPA. So I was thinking of the Palms lab. Well, hopefully IDEX will give you normal ranges and stuff.
They said renin won't have a normal range, but aldosterone will.
Okay. Cool.
But do you know if it's back?
I haven't looked. No.
We'll have a look today.
Awesome. Excellent. What else? I guess we touched on sympathetic nervous system and RAS impact on the vascular system in kidney disease. This is a much bigger problem in humans who get vascular changes secondary to chronic kidney disease, but not so big a deal in our patients, which I think is probably the time that they're alive after they get chronic kidney disease. But the kind of changes, the sympathetic nervous system stimulation causes endothelial dysfunction and a lack of nitrous oxide, which is one of the key vasodilators that acts just locally, not a systemic one, but just a local vasodilator. And that actually causes kind of remodeling of the vessels and decreased accommodation of the vessels. So the vessels are less able to dilate in response to fluid retention. So you then get hypertension at lower blood volume than you would otherwise. So less kind of compensatory capacity in the vessels over long term. So more in chronic kidney disease than in acute. But the local hormone changes or the local chemical changes in the endothelium contribute to the hypertension.
Anna,
yeah.
Can I ask a question? Well, two questions. The first one is the effect of hypertension on kidneys, in blood, I mean, or in urines. You will find proteinuria, right?
If you've got hypertension, usually, yeah.
All right, okay. And the other thing, well, this is, I think, pretty basic, but it's not clear in my head. If you have an animal that has increased creatine, azotemia and hypertension, how do you know which is causing what?
Yeah.
Yeah.
So they kind of perpetuate each other. So you just got to treat both.
Right.
So one, I guess you could have kidney failure from a primary idiopathic hypertension, but once you've got kidney failure, the kidney failure is going to be causing the hypertension. So you just got to treat it.
Right.
Do you know what the impact, how hypertension causes kidney failure or damages kidneys?
I think it decreases the glomerular filtration, but it affects with the, I think, with the vessel tone.
I love this. This is what I do when I'm talking about blood vessels too. I think about it. It definitely impacts vessel tone, but I guess the big thing is that the glomerulus itself has its own blood vessels and its own maintenance of hypertension or maintenance of the blood flow through the glomerulus. So systemic hypertension normally doesn't impact the kidneys at all up to a point of 160 to 180 systolic. And then at that point, that exceeds the glomerulus ability to compensate itself. So it kind of, then all of a sudden, all of this pressure blasts into the kidneys And the glomerular vessels are really thin walled with big gaps in them and stuff like that. So if they're operating under increased pressure, we get edema, we get infiltrates of inflammatory cells, we get fibrosis developing, which is then obviously going to, you know, if you're trying to filter fluid through a scar, it's going to be a lot harder than filtering fluid through a sieve. So the hypertension damages the glomerulus and decreases filtration through that nephron, and ultimately will cause nephron loss. So if you lose the glomerulus, you lose the whole nephron.
Right.
Max, do you have any more sort of, this is off topic, but anything else to add on the impact of hypertension on the kidneys?
Not that I can think of right now.
Sorry, put you on the spot. So the main thing which Catherine mentioned is proteinuria. Do you know why we treat proteinuric renal failure differently from non-proteinuric renal failure?
I think when I was just thinking, like, if you have proteinuria, that means you're leaking protein. That means your permeability of your basal membrane, it's increased, and when protein goes through the basal membrane, they briefly remember the electric charges is going to change, and it's going to further reduce the glomerular function, and also it trigger like more inflammatory signs. So I think that will potentially further kidney damage. So I think if there's proteinuria, we need to treat the proteinuria with either angiotensin receptor blocker or angiotensin converting enzyme inhibitor, and also low protein diet.
Very good answer on the spot. Very impressive. Yeah.
Oh, thanks.
So it addressed glomerular proteinuria very well. Tell me about tubular proteinuria.
I think most of the protein is going to be, if there's small protein that leak out from the glomerula, most of the protein is going to be reabsorbed by the tubular, and if the tubular is not absorbing the reabsorbing the amino acid, then what we worry about tubular function disorder, like they will leak more other thing like acid, sorry, bicarbonate and other electrolyte. Is it something?
Yeah, it's good. Yeah. So there's sort of two things. So leading on from that, you talked about sort of small proteins and large proteins, and I guess the volume of proteinuria with glomerular versus tubular disease. So if you were doing a UPCR in a dog with a glomerulopathy and a dog with a tubulopathy, which would be higher?
I think glomerulopathy.
Absolutely.
Because they leak.
Lots of protein comes out.
And then there's limitation of how much the tubular can reabsorb.
Exactly, yeah, exactly. So UPCRs in dogs with glomerulopathies, usually over 4. If it's under 4, it's usually a tubulopathy, or under 2, and then there's a grey zone in the middle. So that's excellent. And the only thing you didn't mention really that I can think of is the protein when it leaks through the glomerulus. You mentioned causes inflammation and swelling and decreases filtration. That same thing happens in the tubule. So if you've got protein moving through the tubule, whether it's glomerular in origin or the tubule not reabsorbing it, it actually can block the tubule. It inspissates within the tubule and can block it. And then you lose that whole nephron. So obviously need to maintain flow, and anything that increases oncotic pressure and can form a cast will cause tubular damage long term. So it just perpetuates nephron loss. Excellent. Should we move on to hyper A, or do we want to keep talking about kidneys?
Yeah, move on.
Right. Yeah,
sounds good.
Okay, so what is the mechanism for hypertension in hyper A?
Is it increased vascular tone? Generalized?
One of, yeah. Why?
Because of increased cortisol.
Yeah, and
The other one would be increased mineralocorticoid.
yes, good. Yeah. So cortisol actually has some mineralocorticoid properties on its own. So what percentage of dogs, this is just straight out of the textbook, what percentage of dogs with hyper A will be hypertensive?
60 to 80%.
Good, it's really high actually.
sorry, I missed that.
What was it?
60 to 80%.
Oh wow. Okay.
Yeah. And if you've got pituitary dependent or adrenal dependent, which is more likely to be hypertensive?
The adrenal.
Adrenal dependent, exactly. Yeah. And if you treat hyper A with trilostane, does the hypertension resolve?
I'm not sure if it's meant to, but I have seen it.
I'm not sure.
It actually doesn't. In the vast majority of patients, it doesn't resolve. So the mechanism, we sort of think, oh, cortisol is causing fluid retention and increasing blood volume, and you correct the hypercortisolemia and you correct the hypertension, but it actually doesn't work like that. So there's an element of what's the hyper A causing hypertension that we don't understand well enough, obviously, because otherwise treatment should reduce the hypertension. The other thing about hyper A is that it decreases nitrous oxide, sorry, one of the two. Jeff, do you know which one it is?
The simple answer is no, but my guess is nitric, because
Okay.
that's the one that's vascularly active, isn't it?
Yeah, I think so. And nitrous is the one that you get at a dentist, right?
Well, they used to, laughing
All
gas.
Right.
But some people consider going to the dentist as no laughing matter, though.
I'm one of them. That's why I don't know about the gas. So nitric oxide is reduced in dogs with Cushing's. And the reason, what does nitric oxide do?
Vasodilation.
Exactly, yeah. So we've just got decreased compensatory ability. So we've got fluid retention, but then we've also got decreased ability to compensate by dilating the vessels to accommodate that extra fluid. So we've talked about the physiology of aldosterone and a little bit about hyperaldosteronism. And while we're on adrenal diseases, let's talk about hyperaldosteronism. How would you treat hypertension associated with hyperaldosteronism?
Would you treat it directly at the source? So treating the renin-angiotensin aldosterone system?
Did you say ACE inhibitor?
Yeah, like an ACE inhibitor or an ARB. Or maybe not an ARB, an ACE inhibitor.
But aren't you getting direct production of aldosterone? So it's, oh yeah, never mind. He's right.
Well, I don't know if I'm right.
I agree with you, Paul.
Yeah. Oh,
That train of thought.
well, I'm just thinking like you're getting so much aldosterone produced that isn't ACE inhibitor going to be enough? Like you'd have to remove the source of the overproduction of aldosterone would be my thinking. So like if you've got a tumor, I guess remove the tumor and then supplement your mineral corticoids, or you're going to have to, you're going to have to try and increase your excretion. So you'll want to get rid of more sodium. So could you use something like spironolactone or something like that?
I'm so proud of you. That was very good. So this is where the primary hyperaldosteronism and secondary hyperaldosteronism are really important. So your theory is correct, Josh, if it's a secondary hyperaldosteronism. So if it's excess renin RAS activation causing the hyperaldosteronism, an ACE inhibitor should decrease that feedback loop. If you've got a primary hyperaldosteronism, you've lost feedback. You've got a tumour or something causing excess aldosterone production at the source, so usually a tumour in the adrenal gland. And that hyperaldosteronism is not going to respond to stopping the angiotensin. So angiotensin ACE inhibitors, how do they work as, I mean, the indication for an ACE inhibitor in this situation would be blood pressure management. Would that be your first choice?
Blood pressure?
Yeah.
No.
No.
Only like a 10% drop generally, I think, isn't it?
Yeah, it's lame. Paul's suggestion of spironolactone. Why did I get so excited about that? What's its mechanism of action?
Doesn't it increase sodium excretion and therefore you retain potassium? Or
how does it do that?
I got it. I can't remember. Sorry.
Is it like directly or something? I can't remember either. Max will answer it.
I can't remember. Yeah. I'll butcher it.
No, I think it's a potassium sparing diuretic. So
it is. What receptor does it work on? Max knows. Let's let Max tell us.
Oh.
It's great.
No, I don't really know actually. No, I think I should know. And yeah.
It's an aldosterone receptor antagonist.
Yeah.
So it just blocks the effect of aldosterone.
Right.
So it just reverses the exact excess that you've got. So it's really good, effective treatment for hyperaldosteronism. Not as definitive, obviously, as surgery, but it's the treatment of choice. And because you're reversing the effect and the cause of the hypertension, it works for hypertension. You often don't need to use amlodipine or anything in addition to that. Okay, while we're talking about adrenal tumours, FAOs as a cause of hypertension. What's a FAO?
Sorry, I just want to backtrack a bit. With the Cohen syndrome or like hyperaldosteronism by itself, would that cause like severe hypertensive? Like, because most of the time I think like when there's adrenal gland tumor, they often come with the pheochromocytoma is the one that cause more hypertension than.
Yeah. So these cats with cons typically present for their hypokalemia before the hypertension becomes a problem. So if you did blood pressure in them, they'd be high, like 160, 180. Sometimes they get up to 220, but you're more often treating the more emergent hypokalemia at that point.
Okay.
But they're all hypertensive.
Okay. So pheochromocytoma is adrenal medullary tumor that produce adrenal. Oh, sorry, but yeah.
That's right.
Yeah. What's that? It's not. Yeah, I think it's produced adrenal. Yeah.
I just say catecholamines.
Yes.
They can actually produce adrenaline and noradrenaline and just any combination of the two potentially. So what's the effect of
methanephrine? Is it something like that?
Methanephrine is one of the metabolites.
Yes. Yeah.
Yeah. So it's more stable. So adrenaline's so short-lived that if you tried to measure adrenaline in a FAO dog, because they get these waves of adrenaline secreted, chances are you'd get a normal, and also adrenaline's unstable, like getting it to the lab in time to get it assessed, it's an impractical biomarker, whereas metanephrine is one of the metabolites of adrenaline, which is quite stable. So it's kind of like fructosamine to glucose. So we can look at kind of average adrenaline over a longer period with the metanephrine. So what effect does the increased adrenaline have? How does it cause hypertension?
You get increased heart rate,
Mm-hmm.
and you get probably increased peripheral vascular resistance. So, yeah.
Everything.
Yeah.
So what are the clinical signs? What are the dogs going to present with?
Tachycardia. Probably with hypertension. Yeah, that's probably it. Let me talk here.
So clinically, yes, exactly, definitely. But how often do you look at a nervous dog that's presented shaking and looks anxious and they're tachycardic? And yeah, it's really hard to pick an adrenaline surge in a dog that's just presented to you. FAO dogs often have gastro signs, so they'll present with vomiting or intermittent vomiting, and that's associated with the adrenaline surges. And it's often, if you sort of quiz the owners, they'll often have tremoring around the time of the vomit, and they're like, oh, they're nauseous or whatever. But really, it's not until you do a metanephrine creatinine ratio in the urine that you can diagnose them. It's such a vague presentation because it's such a spectrum. Like, you know, a dog presenting to the vet clinic has an adrenaline surge. A normal dog, not necessarily a FAO dog. So really hard to diagnose. All right, we're going a little bit slower than I'd anticipated. Is everybody happy with the rate that we're going? You don't want to?
Very much so. And for my aging brain, it's probably a little fast.
I love it. I'm on the same wavelength, Jeff. So I'll just let my dog go. The next thing we're going to talk about is hypothyroidism. What are you doing?
Seems so nutty.
So hypothyroidism, what effect does T4 have on peripheral vascular tone?
I think, I'm not sure, but does it have something to do with the stroke volume?
So just interested right now at the peripheral vascular tone, the effect on peripheral vascular tone.
Vasoconstriction?
It's actually vasodilation. I knew you'd say that. It's a trick question. Because you always think hypothyroid cats, hypertension, and it's usually not the case. So they're usually, what are you doing? Penny, get on your bed, go. Penny, up, go. Sorry, my cat's trying to attack my dog. Getting messy. Yeah, so thyroid hormone actually causes vasodilation, but then also causes renin-angiotensin-aldosterone system activation and then fluid retention. So overall, hypertension is more common in hypothyroid cats. Max, do you remember the percentage of cats with hypothyroidism and systemic hypertension?
5 to 20.
Yeah, so it's actually not as high as I would have thought. And I think we often see hypothyroidism in conjunction with renal disease, and it's actually the renal disease causing the hypertension, not the hypothyroidism. What about diabetes? Does it cause hypertension?
Yes.
Not in dogs and cats.
Not in dogs and cats. Yeah, in humans for sure. No. Yeah, interesting, eh?
Oh.
Yeah. So the mechanisms are just the mechanisms of diabetes in humans are so different from the mechanisms in dogs in particular. And the vascular effect of diabetes in humans is so different than in dogs that we just don't see it as often. So then the last category is idiopathic, which is pretty rare in dogs. We can usually find an underlying cause of hypertension in dogs. But in cats, we end up calling them idiopathic up to 30% of the time. 20%, sorry, of the time. Maybe I'm overdiagnosing idiopathic. All right, now I have to get to the ocular manifestations of hypertension before we finish up, because otherwise Paul will never come to another tutorial.
I will.
So what do we need to cover? Okay, so the factors that contribute, so we call the effects that hypertension has on target organ damage. And the factors that contribute to whether damage occurs, it's not just a single, like, you know, blood pressure is elevated and therefore they'll get target organ damage. It's more to do with how sudden the changes in blood pressure are. So over a 24-hour period, what the variability is in the blood pressure, how fast it's developed. So if you've got like a FAO, for example, where the blood pressure goes from 120, 120, 120 to 80, you're going to get a lot more kind of like the vessels have a lot less time to accommodate for that. But it's also very short term. So you're not going to get kind of chronic, you know, cerebral edema associated with that. You're going to get ruptured blood vessels or stroke associated with that. And obviously the magnitude, the higher it is, the more severe it is. So the table in Edinger says that essentially over 180 should be classified as severe risk of target organ damage. And they actually have 5 target organs in Edinger, and I usually did 4, or 5 systems. Can anyone tell me what the 5 systems that are impacted by hypertension are?
So the target organs?
Yes.
So the kidneys,
Yep.
the eyes,
Yep.
the cardiovascular system.
Yes.
Brain.
Good. Thank you. Welcome.
The brain. Yes.
So Edinger has just broken down cardiovascular into 2 systems, which is why there's 5. So you've got them all. Yeah, you got them all. So let's go to the ocular because we've only got 9 minutes left before round starts. Paul, can you tell us what the ocular manifestations of systemic hypertension are?
You get so you get retinal hemorrhages.
Mm-hmm.
You get vascular. I can't say the word. Tortuosity, but that's more common in humans, and you don't actually see it as much in animals. And then detachments are the key ones.
Excellent. What can happen in the anterior chamber?
Oh, you can get hyphema as well.
Mm-hmm.
Yeah.
What about iris?
You can get ruptured vessels in the iris as well, I'm pretty sure.
Good.
Yeah. I always think about the retina, but it's really good. Yeah, I forget about that.
Yeah.
I'm just, yeah.
So how are you going to detect this clinically?
So usually like they'll present with sudden blindness, and it's kind of a signalment thing, I think. Like if you've got like an old cat with sudden onset blindness, like you should be suspicious about, you know, a retinopathy and then systemic hypertension. And yeah, you can do like your, you know, like your menace and your palpebral and your menace, sorry, and the pupils will tend to be dilated. And then if you can do a good like fundoscopic exam, you can see the detachments usually pretty clearly. And you can see the bleeds as well. Sometimes you can see the detachments without even a fundoscopic exam. You can just see sort of like the curtain just folding behind them. They're really bad, yeah.
It's a good way to put it.
Yeah.
Is everybody happy with the appearance of a detached retina? Yep, cool. Just me. Just kidding. I don't like doing funding exams. I make Paul do them all. Okay, that was good. Excellent. So I do want to talk about, we talked a little bit about the renal target organ damage, so I'm going to leave that for the moment, but I do want to talk about the nervous system impact because I think it's probably underdiagnosed. So often we get these old patients that are walking in circles, particularly cats, walking circles, clearly encephalopathic or have like cognitive dysfunction. And I guess there's been a few patients where I've detected hypertension and I've treated it with antihypertensives and there's been an improvement in cerebral function. But I think there's probably a lot I've missed that were maybe tied in with other diseases that I didn't sort of focus on the hypertension and that the hypertension was contributing to the neuroscience. So I think it's just a good reminder to go through this. So how does hypertensive encephalopathy develop?
Like a vascular accident?
It's one cause for sure, yeah. So stroke, absolutely. How would that present clinically?
Very acute onset of neuroscience, possible lateralizing to one side.
Good.
And they're having high blood pressure.
Yeah, good. Do you know, this is off topic and probably more detail than the chapter provided, do you know which artery is the most commonly infarcted artery?
Thalamic artery.
Which one?
Thalamic.
It is, the thalamus is the most common region, but it's not called the thalamic artery.
Not too sure.
Rostral cerebellar.
Rostral cerebellar.
Yeah. And there's a lateral, I can't remember what it is, like one side's more common than the other, just with the way that the vessels branch, that's just the path of least resistance for clots to go to. So in your experience, patients that present with vascular accidents, what would be the most common presenting, like you've sort of mentioned, lateralized neurosigns? What neurosigns?
Ataxia. I was just thinking like if it's right-sided thalamus, then it should be having is it ipsilateral or contralateral?
Still contralateral.
Contralateral, yeah.
Yep.
So right-sided contrascopic receptor deficit on right side body. If
it's left-sided.
Oh yes, contralateral. Yes, so yeah. So it should be left side. And like if we think about right side is more common, then it should be left side. Turning to the left side.
Good, excellent. Yeah. And I think that's probably the most common thing that I see is a torticollis towards the side of the lesion and crab walking. So as far as like thromboembolic stroke, that's the most common presentation I see. So that's one effect of one cause of hypertensive encephalopathy, but well, one cause of target organ damage, but hypertensive encephalopathy is kind of a different syndrome and it's more with very chronic hypertension. So over time, the blood-brain barrier breaks down under increased pressure. So the brain is really good at controlling its blood flow. But again, same as the glomerulus, it's got to cut off, and over 160 to 180, you'll start to get increased blood flow to the brain, which will damage the blood-brain barrier, and you'll get, over time, cerebral edema developing. What happens when you add fluid? What happens to cerebral perfusion pressure when you get cerebral edema?
Increase.
Good. Excellent. So what happens when you treat hypertension in a patient with encephalopathic signs associated with the hypertension?
The hypertension is somewhat protective, isn't it, at that point? Because there's increased cerebral pressure. So you need that hypertension to get blood flow to the brain to overcome it. So if you take away the hypertension, then you're going to reduce blood flow to the brain. So you need to address the intracranial pressure first. So
that would be ideal, except it's the hypertension causing the increase in intracranial.
Yeah, so what do you do?
So hard. So the main thing, you just got to drop the blood pressure slowly. So you can't just halve it. So if they're sitting at 200, you're not aiming for 100, you're aiming for 160, 180.
Okay.
So you just start amlodipine. If they've got neuroscience, start your amlodipine conservatively and work your way up. So while we're talking about that, amlodipine, which is the it's what we always use for hypertension. It's definitely my favorite treatment of hypertension. Why would you work your way up in situations other than cerebral edema?
I guess you don't want to overcompensate, or no? Not really.
Yeah, I mean, you don't want to drop, but you don't want to change it too fast in most situations. But essentially the receptors are like, I can't think of the word. I wrote it down somewhere. The receptors essentially get used to the amlodipine, so they get less responsive to it over time. So you quite often have to start low and you get a great response, and then the hypertension becomes refractory. That's the word, refractory, to the amlodipine, and you've got to increase the dose of amlodipine as you go. So we are actually going to have to wrap up, which is probably a good time to do it because we managed to talk about the eyes. That was a really interesting chapter, but I think we will have to sort of keep pushing through rather than revisit this with the next couple of chapters of Edinger. So I'll send out an email with which chapters they are and what the topic's going to be. But I think we're heading... Does anyone know off the top of their head?
I think you're on the next. I think we just the next book now, isn't it?
No,
Oh no, it's
next
one
section.
next section.
Oh, it's really boring. So therapeutic considerations in medicine and disease. That sounds quite broad. Antibacterial drug therapy. Okay, I'm going to give you all a talk on infection control.
Yeah, that'd be good.
In 2 weeks' time.
Cool.
Or an responsible use of antimicrobials. All right.
Yeah.
Thanks, everybody.
Thanks,
All right. See you all.
Thanks very much.
Bye, Paul.
No worries.
Thank you.